Hello, everyone, and welcome to this webinar on Sustainable Cities for Health Equity, hosted by the Global Working Group on Social Determinants of Health. Now, before we begin, I'd like to acknowledge the traditional owners of the land from which I speak, the Wurundjeri people of the Kulin Nation, and I pay my respects to the elders past, present, and those emerging. I also extend the respect to any Indigenous colleagues and people who are attending this session today. So this talk today, we've got three fantastic speakers, and I'm presenting this on behalf of our colleagues from the Global Working Group on Social Determinants of Health. I have to say that it has been tremendous amount of work put in through this group over a decade nearly now, and I sit on shoulders of my fantastic colleagues who help work in this group. This is a really important webinar for us because it does set the tone for some of the specific aspects of social determinants that we as a group are interested in taking on in near future. And also to say that you're more than welcome and you should attend our specific supplenary around precarious employment that will be in the next World IUHPE conference. So without further ado, I'd like to invite our first speaker, who is Professor Hannah Badland. Professor Hannah Badland researches how improving the livability of cities through better urban design can enhance health and well-being and reduce inequities. Her research examines how the built environment is connected to health, well-being, and inequities in both adults and children internationally. Now, Hannah, if you can, I'll stop sharing my screen, and if you're okay to share your screen so that you can have the stage.
Sure. Okay. All right. Is that okay?
Yes, it looks good.
Looking good? Great.
Yeah.
Oh, well, thank you, Ankur, and thank you everyone for coming along. I understand it's, for those of you in Canada, it's a late night, so we do appreciate it. I'll also like to start with an acknowledgement of country, and so I'm conducting my business today on the Woiwurrung and Boonwurrung on the lands of the Woiwurrung and Boonwurrung language groups of the Eastern Kulin Nation. And I respectfully recognise the sovereign relationship and acknowledge the traditional custodians of country and elders past, present, future and emerging, and also other First Nations groups who the land that we conduct our business on. And I uphold the notion that if we care for country, it will care for us. So thanks for the introduction, Ankur. What I'm going to speak about today is the association between the built environment and health at a very high level, but also take it one step further in terms of framing it around some tools that we've developed that can actually be used by policymakers and practitioners for designing built environments that do support health, well-being and inequity through acting on the social determinants of health. So knowing that the relationship between the built environment and health is actually really old, it's nothing new. The Romans knew about it with sanitation. Many of you will be familiar with the cholera epidemic and John Snow and the Broad Street Pump in the 1850s. But what we've seen more recently, and largely from the 1980s, was through the Healthy Cities movement. And that's the understanding of the relationship between the built environment and more of a focus on non-communicable diseases. And more of a population focus as well. And quite recently, that's sort of been more rebadged around the UN Sustainable Development Goals, which has got quite an explicit focus on the built environment to some extent, but a bit more broader around the wider environment, health outcomes and prosperity. So why are neighbourhoods and cities useful for improving health? Well, there's a population-wide impact. So wherever the dose is delivered, anyone who's living or working or socializing in that area will receive the effect. We can generate sustainable change. So if you put in, let's say, a pub, like a rail line, it's sustainable. It's going to be there for a long time. And so you do tend to operate on what we call the upstream or the social determinants of health. So it might be transport, it might be employment opportunities, it might be a new school, which helps support education as preventive approach. So it actually gets a lot of the population before they present with the disease. And in terms of when you're thinking about that from a health economics perspective or a social cohesion perspective, it's really great to get people before they're sick. And then even if people are along the pipeline to disease, they're also being picked up, and hopefully there'll be behavioural changes that can actually change their trajectory. And lastly, which is possibly becoming more important, is around the co-benefits. So again, for example, let's say you put in more public transport infrastructure, you'll see a reduction in greenhouse gas emissions. So that's really important to think about it, particularly within the Sustainable Development Goal context, where we are trying to get co-benefits in anything that we do. So there has actually been a lot of policy documents out there in terms of how we can think about creating environments that do support good health outcomes. So how we can make places more walkable, how we can create environments that support different populations, such as age-friendly cities or child-friendly cities. All of these are really great. They come with checklists and metrics, often broad sets of recommendations, but where we've had a bit of a mismatch is between the actual evidence base and generating really high quality data that can then be used by policymakers and planners in terms of actually guiding where they place interventions and how they do it. So that's something that we've been focusing on for quite a while in terms of my research group. We know that there's a really, really strong political will, but often there's a mismatch between how we get the information across to them from the research community in a readily usable format. So this, very high level, and I'm more than happy to share papers with you if you'd like to contact me afterwards or engage in a conversation. But what we've coined as livable neighbourhoods, and this has come off of many years of research by our research group, previously at Melbourne and now at RMIT, and before that at various different appointments. But what we sought to do, this was led through a Centre of Research Excellence, which was led by Billy Giles Corte, was about trying to understand what are the critical ingredients for neighbourhoods in terms of the built environment structure that support good health and wellbeing outcomes. And this was conducted after a fairly substantial literature review, but we looked at these different domains that we found were really important, being employment, food, housing, public open space, social infrastructure, transport, and walkability. And what we set about doing was conceptualizing the actual pathways to how they impact health and well-being, and then empirically testing them through creating a series of spatial measures. So these are all spatial, they were spatially defined and created as a series of indicators to actually understand whether or not they do shape health and well-being. And to our knowledge, that empirical evidence base hadn't actually been established before. And that was a really important step for us in terms of our research program, in terms of framing spatial indicators that were policy relevant and then could be used to actually guide how we shape the built environment. And perhaps more so given as we move into the post-pandemic recovery, we know that neighbourhoods are being incredibly important, particularly as people have been put into various levels of lockdowns or neighbourhood restrictions. So thinking about how these critical ingredients shape what people have available to them as we move forward, it's going to become more important. So a lot of our work, sorry, I'm just trying to change slides. A lot of our work now has been around taking this evidence and shaping it into indicators. And the reason why we've chosen indicators, and these are spatial indicators, are that they can be used as really powerful tools. So they can help guide policy in quite a digestible way. So you can understand that if you have public transport within, how many people have public transport options available to them within 400 metres? So yes, no, and then that's a policy directive, at least in Australia. You can also use it to measure and monitor, so see how to understand what the current state of the neighbourhood is, and if any interventions are put in place over time, how that's actually shaped the neighbourhood. That can also help guide where interventions need to be put in place, so if something's really missing from a neighbourhood. And also can be used as a democratic tool. So that's about thinking a bit more broadly, like in terms of how we can shape the citizen debate, the citizen science. How can we empower people to be able to have conversations with their like the members of parliament, for example, or their policymakers, in terms of actually saying, hey, we really need a school here, we don't have one. So that's sort of why we've gone down the indicator framework in terms of, I guess, providing a way to take our evidence and actually make it used in terms of how we create a built environment. Now, I'm just going to show you a really short video. This is of the Australian Urban Observatory, and it's one of our main, well, it's our primary indicator product that has come out of the our evidence base, but it's tried to shape decision making. So it's quite high level, but hopefully it will give you a sense of the ways that the indicators can be used in terms of visualization tool and bringing people along with us. Okay.
The Australian Urban Observatory is your map to livable cities. It's a groundbreaking digital platform that transforms complex data into visual and easily understood domains of livability mapped across Australia's largest cities. The Australian Urban Observatory measures livability across cities, council areas, suburbs and neighbourhoods, helping decision makers to take action that improves the health and well-being of our communities. Let's say you're a policymaker who's trying to find ways to improve the livability of your city and encourage an active and healthy lifestyle for your residents. You can easily understand the walkability of an area, as well as access to schools, public transport and public open spaces to help decide which areas and people need resources the most. You can even look at other neighbourhoods and suburbs across the country to find out what is working in comparable geographic or demographic areas. Or maybe you're a developer looking for the next place to invest. You can start by looking at indicators of housing, employment, access to shops and community services at a suburb level, and then narrow down to individual neighbourhoods. Here, you can determine exactly which area is ready to welcome more people. You might be learning about livability at school.
So sorry, I've got the video talking to me, so I'll just talk about it. So in terms of what we can see is that it's a tool that actually visualizes the different domains of livability. So you can look at what places in the environment, in terms of your neighbourhood, what is actually the distribution of, let's say, public transport or public open space. And it's all based on, here we go, this is great. I'm just going to pause that. Now I can talk without having someone talking at me as well. So basically it's a tool where you can visualize the built environment, and in terms of the domains, what is actually being delivered in the local neighbourhood. And so that's really useful in terms of policy. When we're working with developers, for example, if they're looking at building a new housing development, for example, where is a good place to situate something that can provide access to public transport? There's local employment opportunities, there's a local school, there's public open space. So it's about thinking about the ways that we understand our built environment, and then where we actually build our populations, or how we can better support our populations to enable to live enriching and fulfilling lives. So this tool, probably some of the, I guess, the important parts of it is that it's based on evidence, but it's also able to be aggregated at different levels. So you can look at it from a suburb level, you can look at it from a neighbourhood level to understand how all the different dimensions work together. And it's something that we've had a lot of traction with. And I'll just move to the next slide. Here's just an example of how this information's being used. So we've got it's now been used in lots of government documents and lots of government policies, particularly around how you actually build optimal compact cities, or 20-minute neighbourhoods is what they're called in Australia. UN Habitat's picked it up in terms of being inspiring practices and ways to engage with actually shaping how built environments are created. There's been quite a lot of interest from health agencies, which is great, and that again really solidifies that collaboration between what we're seeing as built environment or sense of place with health outcomes. And then also we've had a lot of traction within local councils. So they actually want to know, how do we create built environments that do support better health and wellbeing outcomes for our people? So there's been a lot of traction, and I think moving forward, again, knowing the importance of what the neighbourhoods have played in this, throughout COVID and in this post-pandemic recovery, particularly now that there'll be a lot more hybrid models of people working from home, at least for part of the week. How do we create these environments that actually provide people the resources that they need? So I'll leave that now. I possibly have gone a little bit over time, but more than happy to answer questions in the discussion. Thank you.
Thank you, Hannah. Can you all see my screen? Can you all see my screen?
Yes.
Good. All right. Thank you, Hannah, for this presentation, and sorry for the technical difficulties. So maybe we can share the link to the video later, and people who want to see the video, they can have a look at it. From measuring livability, we're moving towards a more sort of focused assessment of Latin American countries in terms of social determinants. And our second speaker today is Dr. Gerry Eijkemans. And Dr. Gerry Eijkemans is the Unit Chief of Health Promotion and Social Determinants at PAHO, WHO. And the focus of her work has been on working and employment conditions, health promotion, social determinants of health, and the link with health system strengthening. So, Gerry, if you can share your screen, and I can make sure everything is good. Let me stop sharing my screen first. And if you can share your screen.
Let me know if this works.
It did. All
Okay.
right, I'll put myself to mute and you can start now. Thank you.
Wonderful, wonderful. Thank you. Thank you very much, and wonderful opportunity of being here with you this evening. So I'm going to talk a bit about cities and health equity and some lessons that we are learning from the Americas in times of COVID. I want to do a little exercise how we start this when we talk about cities. I want you to think a moment about your city, about that part of the city where maybe you were born, but where you don't live anymore, and where you don't want your daughter to go at night, where poverty, social problems, exclusion, and violence rule, where COVID has been much more damaging than in other parts of the city. That's our collective debt, and that's what I'm going to talk about in the few minutes I have now. So first of all, want to look at the Americas and urbanization. The region of the Americas is the most urbanized region in the world. Since 1970, the urban population here grew with almost 190%. The region houses 8 megacities, and 80% of the people in the Americas live in cities. And we also have huge inequities in the cities. People across the Americas are some of the most technically connected people, providing opportunities for the use of innovative technologies. This is a slide that I used to use before the pandemic, where we already saw the huge inequities within cities. And in this case, I use the example of Washington, D.C., where I live, where we have a metro system where the red line of the metro between Washington, D.C. and Shady Grove in Maryland has 17 stops spanning over 30 miles and an estimated 9-year difference in life expectancy. So that was the reality before COVID. Now, I don't have the new map, but I am absolutely sure that the 9 years are no longer valid, but it's much larger than that. So COVID came to the Americas early, and it's still, this region is still the most affected region by COVID in terms of in absolute numbers and also in relative numbers. So it came to the Americas in an already complicated socioeconomic context with huge inequalities, huge inequities that I already mentioned, An informal economy over 50%. In some of the countries like Peru, it goes to 70, 80% of the economy, of course, characterized by exclusion. And what COVID did, and we've all heard it, we've all talked about it, it has magnified and it has deepened the inequalities and the inequities in our countries and in our cities. Just one number from the region, in Latin America, we have seen a 14-year regression into our poverty reduction strategies. We're back at the levels of 2004, 2005. So this is a huge step back, and this is going to have an impact over the coming years when we talk about recovery, of course. So when we started to look at the response to COVID in our countries and our cities, we started to see that vulnerability was a key concept. We asked some questions. Why was the implementation of public health measures not more effective? Lots of lockdowns in this region, absolutely severe in some countries, and still the effects were not there. How was the socioeconomic, cultural, political context taken into account when the formulation and implementation and adaptation of those measures happened? And how was the heterogeneity of the needs of the social groups considered when we implemented those measures? And what we found is that we need to adjust and to broaden the perspective of what we call population situation of vulnerability to make it relevant for the response to the pandemic. The approach of vulnerability too often was mainly focused on the biological and the individual attributes and focuses on risk factors and on mortality. So we found that we need to go beyond this biomedical individual characteristics. For example, we say, who are the vulnerable? The elderly, the women, the children, the ethnic groups, those living with chronic diseases, those with obesity, and we need to take into account the social conditions. So we developed this model that's extremely helpful in looking at vulnerabilities. And very much, of course, the social determinants of health focus. So if you look at the layers of the onion here, the structural barriers of the vulnerability, it talks really about the socioeconomic and political inequalities that was pre-existing before the conditions that have gotten worse, that have increased because of the pandemic. Think about migrant populations, think about those who already lived in difficult conditions, their situation is worse now. But then we also saw that there were barriers to the implementation of the public health measures and their adherence. So there we see, for example, that workers in the informal economy could not stay at home and because they would lose their income, so they had to go out. So this is another layer of vulnerability. Then we see that some groups were more affected by the measures like social distancing or physical distancing, and there, the people who live in small spaces, in crowded spaces, we saw there very much that, for example, violence against women went up significantly in those situations. So, and then of course there's that last bit that everybody talks about is who have died. Of course, these were the people with pre-existing comorbidities, etc. But this is not necessarily what we're talking about. So who are those populations and what are those drivers? It's labor, the different categories of workers, the informal economy, self-employed, etc. Housing is a driver, people living in inadequate housing and in crowded spaces, in different kind of institutions, social exclusion, migrants, people living with disability, indigenous populations, Afro-descendant populations, the homeless, the social support and the burden of care, very clearly with the women had households, etc. And then specificity on the territories. And the territory again can be the urban informal settlements or the remote rural areas. Now I'm trying to move to the next slides, and one another way I'm stuck. Okay, so we developed a guidance document. Here is a link. I'm not going to a whole lot of detail, but we then developed guidance for countries, for decision makers, and for city leaders to take into account when implementing public health measures. Specificity at local level, of course, are those informal urban settlements and the urban areas with high population density. And also the other extreme are the remote communities and our indigenous territories, where some of the problems that came out very clearly is the lack of regular water supply, limited green space, the risk of crowding, and limited availability of and access to essential services, health services, food, hygiene, disinfection products, etc., and other services. Now, so based on that, we developed recommendations for local authorities. And here are 5 of the key ones. First, to adapt public health strategies with COVID and in general, and public health measures to the specificity and the socioeconomic context of the local level, including when managing transport, public space, safe delivery of supplies, etc., and services, etc. Here, I always give the example of hand washing. You know, when we talk about the message we gave, the public health message we give to people is wash your hands with water and soap for 3 minutes, which is absolutely important. But we do not talk and think about how do we give that message to those who do not have access to water and soap, etc. Then other key recommendations is to prioritize the provision of basic services and guarantee the availability of those services in informal settlements. Install and guarantee the availability of water, public hand washing facilities in places where sufficient access to water is limited, guarantee access to mental health, psychosocial support services, and facilitate local dialogue with the communities, including migrants, indigenous populations, persons with disability, women, young people, etc. This can never, ever be only something decided at the top, but it has to be in dialogue with the communities. So we are saying we have this urban health imperative need to act on in our cities in the Americas, and we use the model of healthy cities committed to social justice, action on social determinants, health in all policies, and community participation. Healthy cities that seek to distribute resources justly to create inclusive, safe, resilient, and sustainable cities. And healthy and smart cities that use data and evidence for inclusive governance that meets the needs of its people across the city. So then the key points here, the key takeaway for the cities is move towards universal health with a focus on primary healthcare, not the investment in the huge hospitals, but really at the primary healthcare level, also in our cities. Ensure universal social protection. That was absolutely key, and that will be key in recovering with equity. Create decent work for everybody with a decent income. Provide adequate housing. Provide universal connectivity. And I think we heard about it and we'll hear more about that. Strengthen preparedness and response planning. Create a health promoting transportation, walkable cities, green spaces. Use innovation to create health and really reduce inequities, because if we do not do that, we will not be able to overcome this COVID and reach the next one. So and the next pandemic that might come. So I want to take you back to the beginning, and I want you to imagine again your city, resilient, healthy, safe for everybody, a city where you can walk everywhere, where you can go on your bicycle, where there are no food deserts, a city where everyone has an opportunity, where all basic needs are covered, where people can live with dignity, a city where health is enshrined in policy and protected as a priority. Will we learn from COVID and take the opportunity that we are offered and to really build cities like that? That's my question with which I want to end this presentation. Thank you.
Thank you, Gerry, for your really inspiring and interesting talk here. Now, our last speaker for the webinar is Dr. Priya Balasubramaniam. And Dr. Priya Balasubramaniam is a public health professional with over 20 years of experience in large-scale implementation, research, education, and program planning in academic, non-profit, and government setting. I recognize her as an expert on universal health coverage. In addition to her latest, she's a co-founder of the mutual learning platform for mixed health systems in response to the COVID-19 pandemic. So Priya, I'll stop sharing my screens, and if you can share your screen, and I'll put myself to mute.
Thanks, Ankur, and good morning, good afternoon, good evening, everyone from whichever part of the world you've joined us. I'll be talking a little bit on continuing on the previous two speakers' points on sustainable cities for health equity, and narrowing down the focus now and moving you over from the cities of Latin America to perhaps some of the mega cities in South Asia. So I'm going to be talking a little bit about leveraging urban, digital, and innovative non-state health partnerships for improved access and equitable service delivery in a post-COVID-19 era. So I will be sticking to the topic of choice. Whether we like it or not, we are stuck with COVID for some time to come. But what I'd like to talk about is also the kind of health system changes that has happened as a result of COVID-19. And in some ways, that's actually been quite positive. Especially from an urban context, because COVID-19 invariably, rested and nested within cities. So 4 lessons that kind of emerged on how COVID-19 really forced new levels of agility was, one is that it definitely brought a power of unifying purpose on full display, because for the first time, I think governments, including urban and municipal governments, began to think about responding to the pandemic across sectors. There were multiple sectoral forces at play in order to respond to population level interventions to tackle COVID. The second was that risk tolerances changed almost overnight, and the disruption brought about by the pandemic really reduced the resistance of risk of both private and public sector to both experimentation and taking risks. So governments have been willing to try new things without really being certain of the outcomes. And this has led to a lot of digital solutions and innovations in treatment technologies, supply chains, telemedicine, and so forth, which have been possible largely because of the relaxed barriers to innovation in response to the pandemic. There has been attempts by urban as well as municipal governments to manage transparency, along with decentralization in many urban areas to foster accountability. And also a newer clarity has emerged about our understanding about what work is really essential, what do we focus on, and how do we do that. But even as urban systems began to grapple with the ongoing challenge of COVID and the various symptomatic exigencies that COVID produced, health systems would also had to deal with other disease burdens or the co-burdens of health, non-communicable diseases, which was an unfinished agenda, and of course, the other communicable diseases and maternal and child health burdens that health systems had to face. And all this actually ended up in many emerging economies, digital solutions that came around to augment capacity gaps within governments. And these were patient-centric digital solutions, there were diagnostic-centric solutions, and then there were solutions that focused a lot on research and development, whether there was vaccines or supply chains or healthcare self-monitoring. It really brought about a slew of solutions that began to augment capacity gaps that states could not necessarily provide. And these were in general used across the health system's life course. They were used to improve diagnosis and screening, enhance coordination at primary level, improve data collection and surveillance, and also increase patient education as well as awareness promotion of health in general, as well as in response to the pandemic. In fact, very interestingly, in India, the adoption of digital health during COVID-19 really escalated, and between March and May of 2020, the number of clinicians using teleconsultations and digital platforms reached almost 85%, and 80% of a lot of those consultation services were first-time users. So what I'm going to talk about a little bit today is how this has really fostered new types of health partnerships. What does this really mean for equity and inclusiveness? And how is this going to pan out in a post-COVID world? So how do city health systems have to deal with this new disruptor in terms of health systems, which is digital health disruptors? So one case study I'd like to present is from a state in India called Maharashtra. It's a Western state, a Western and Central Peninsula state. It's also one of the most populous states in the country, with a population of almost 124 million people, and houses one of India's biggest mega cities, the city of Mumbai, which has a population of about 20 million. Maharashtra was deeply affected by the Delta variant earlier this year, and from March to April, it actually ravaged the state across several districts. The state health system was really grappling, was unable to deal with the volumes, both in terms of testing, cases, and tracking, and so entered into a very interesting and, if not strategic, collaboration by a consortia of non-state providers called the Action COVID-19 Team, or ACT, along with the Maharashtra State Innovation Society and the government of Maharashtra. We did a rapid review of this partnership, and I'm going to share a few findings from that review in relation to equity and inclusiveness. So the ACT grants is a very interesting consortia. It was brought together by a network of health leaders, basically private companies, private equity, and the Indian startup company to fight against COVID-19. They pooled their funds together, and this enabled about 54 Indian startups, not only startups, but more mid-market technology companies, to scale through the pandemic with innovative and impactful solutions around prevention, around PPEs, basically responding to every aspect of COVID: testing, tracking, monitoring, surveillance, and treatment. So basically, it was to award grants to technology-driven companies, to connect these companies to local, state, and national governments, and then to help these companies to eventually scale by bringing together networks and startups with additional grants. That was the whole point of ACT. They, in turn, partnered with the Maharashtra state government and across a range of services in that state, and have now actually expanded to almost 25 other states other than Maharashtra. So they dealt with telemedicine, home quarantine, oxygen therapy, patient monitoring, personal equipment, and as well as mental wellness. So it was really a slew of areas where they began to augment gaps in state capacity. From this, our review, actually, I'm going to pick two of these partnerships. So these are partnerships with states, Indian states, and they are interesting for two reasons. So the first one is a company called Step One, and this was really funded by ACT. Their model is quite interesting because they engaged almost 20,000 volunteer doctors from across the countries for roughly around 3.6 million consultations from June 2021. They currently have expanded and working in 22 states, and at the peak, they handled almost 45% of India's COVID-19 cases. They dealt with home isolation, COVID-positive triaging, plasma management, as well as a state COVID helpline that dealt with primary health care issues in home care management around COVID. So what you see here is a lady doctor who's successfully completed over 200 plus COVID screening as part of this partnership. So this is entirely volunteer driven. They partner with the state and have been funded by this interesting consortia. The second is something called Eijkemans, which is another company that was incubated as part of this. They use revenue from CSRs, or corporate social responsibility revenues of companies to run their business. And they actually stepped in to kind of augment gaps in mental health and well-being. So they had over 10,000, it's 1,000 here, but they had over 10,000 psychologists and counselors speaking more than 10 languages to address a range of healthcare workers who were battling COVID. So they were frontline workers, grassroots level workers, state government, personal staff, as well as COVID-19 patients, to kind of counsel them across a range of mental well-being. So they started out in one state and have now expanded to close to 12 states. So we did a basic rapid review analysis of these two companies. And what I'm going to now share is essentially what this really means in terms of implications for digital ecosystems as a determinant of health. I think digital technologies, as these companies have shown us, are really driving health transformations both directly and indirectly. And that says a lot. But before kind of moving on to this final slide, when we were looking at both step one as well as Eijkemans, we asked them a couple of questions around design. And the fundamental question was that when you were developing your technology, whom did you have in mind as a target audience, and what did you really do to shape your technology to kind of address these vulnerable populations? And interestingly, one of the things, the answer with both the companies were the same. They were largely reactive technology companies that were responding to priorities set by the state, but very few of them really deep dived into looking at the vulnerable populations or the last mile populations they would essentially serve. And that's where the whole issue of inclusiveness began to be highlighted, even in their thinking about technology-driven design for health systems. So since digital technologies are driving health transformation in a direct manner, applications through health systems, healthcare, self-monitoring of health status and behaviors, and indirectly through influence on social, commercial, and environmental determinants of health, achieving universal health coverage in a digital world will not only depend on rapid pace of adoption of new technologies in healthcare and health systems. It's not about taking up something and taking that up quickly. It's really about diffusing technology to populations who can best use them most effectively. So governments really will need to adopt a more mission-oriented approach to digital health innovation. And this approach has to diffuse the benefits of digital health technologies equitably to make their deployment more economically feasible, as well as to decentralize and democratize their control. And what I mean by this is really highlighted in some of the areas that I'm going to talk about here. One is to measure inclusiveness. So what is inclusiveness? So access to digital health is not merely related to owning a particular device. It invariably is about a combination of health literacy, ownership of a smartphone, material resources, as well as technical skill, as well as a social recognition on the part of a particular digital solution of the health needs and inequities that they're hoping to address. So let me give you a simple example. When India had the vaccine rollout, they had an app called CoWIN that was rolled out by the central government. But one of the biggest challenges of that application was that a large swath of the urban elderly populations, as well as rural peri-urban populations, couldn't use it. It was too complicated. They could not enter relevant data. And though they may have had an access to a smartphone or even a not so smartphone, they ended up actually going to vaccine centers to actually have their information entered and their vaccine certificates downloaded in real-time pieces of paper. So this ability to really understand the populations that you're targeting as part of a digital solution has to play a much greater role as these digital disruptors begin to take larger and larger roles in urban health systems. So that's the first. Second is measuring inclusiveness. So effectiveness of an intervention was often measured by a lot of these companies. They were measured in terms of coverage, reported outcomes, and other key stakeholder assessments. But much less of that really focused on the inclusiveness of the population that they were aiming to reach. Assessment of the populations themselves. Are we targeting the elderly? Are we including the elderly? Groups that were reached or excluded by a particular services. Do people have cell phones? Is there digital or is there digital architecture where we're trying to kind of apply a particular solution? And explorations for reasons of exclusion or linking to multiple forms of vulnerability. So if it's going to be a hard to reach area, why are people not using a particular app? Or will telemedicine or teleconsultations be an absolute answer to populations that are used to going to the local health center? So a lot of this was some of the missing pieces that we found in this juggernaut of digital health innovations that were flooding urban health systems. The second is the lack of digital architecture and privacy. So the collection and use of health data has to be based on the concept of data solidarity, while simultaneously protecting individual rights. So using data as a public good is very important. Sorry, yes?
I may need to interrupt. You may need to finish in a minute or so.
So this is the last slide. And finally, the last 2 points are consulting communities for digital co-design. So it's very important to include vulnerable communities to create digital co-design for a particular solution. And a lot of this has to incorporate a range of stakeholders. And finally, regulation and accountability. Many governments do not have the capacity to deal with the agility of technologies, but often struggle with many issues associated with integration of digital platforms and services. So regulatory reforms has often lagged behind. And there's a need for global governance and architecture that creates trust in digital health by not only enfranchising patients and vulnerable groups, but ensuring that health and the regulation of digital rights is a universal adage. And this has, of course, resulted in terms of facilitating new partnership models, as you've seen now, integration and adapting beyond COVID, which is needed for survival. The result of new intermediaries, so organizations that bridge between digital companies and the state to enable a more trustful relationship between technology and the populations that they serve. And of course, the role of rapid learning and research, where researchers can play an important and if not objective role in engaging stakeholders and shaping the way in which these sectors could work with each other. So I'll stop over there, Ankur, and sorry for running over my time. Happy to handle questions. Thanks.
Thank you, Priya. If you can stop sharing your screen, excellent. So it would be great if people can ask a few questions, but it seemed from the 3 presentations that sort of, housing, labor, health, and, neighborhood itself, like emerged as the key areas to act for social determinants. If we want to, something I wanted to pose to the, speakers here was, what about vaccine effect, like equity in vaccine distribution now, given that in the post-COVID world, what we are observing is inequities in vaccine implementation and holding to some extent. anything you can comment upon how big that will play a role going forwards? And here also from your Latin America, like regional perspective, how big do you think that will be an issue?
Yeah, thank you. Maybe I could start. Of course, this is, if we talk about equity and health and COVID, this is the big issue at the moment. And obviously, the lack of vaccine availability in most countries in the South is and will remain a huge challenge. And it's of course very challenging for the countries themselves. Now in some of our countries, you don't even have vaccines for our healthcare workers, let alone the rest of the population. Although things are changing a bit, we are setting up vaccine producing facilities in Latin America. So I think we are going to get a very rapid rollout. But it's not only for the countries themselves, it is in general for overcoming the pandemic, because as long as we have, as we all know, a large circulation of virus, there's a very high risk of mutations. So that's why we keep saying until everybody's safe, nobody's safe. So it's huge. And I think this is not over yet. Yeah.
Thank you. Hannah, there's a question from Paula Swinford. I think that's directed to your presentation. Paula, do you want to unmute yourself and ask the question, if that's okay? Or I can read it. So it is, what role do intact ecosystems of species other than human influence the livability of a neighborhood? I do not want to live somewhere without native plants, pollinators, insects, birds, and other mammals besides Homo sapiens.
Absolutely. That's a great question. And I think we need to frame built environments and the ingredients. So I just focused on the social determinants of health in terms of being quite focused in this presentation, but sustainability, biodiversity, absolutely are all part of this picture. And I think that's part of where the Sustainable Development Goals, I think, broaden the scope when we think back to the Millennium Development Goals. This is much broader, and it actually understands more of an ecosystem and the role of humans within it. So we do need to think about how we preserve our environments, how we do create diversity and how we support diversity. And just even in terms of thinking about the Australian context, just we're getting this push up against urban growth boundaries and moving into green space, and what was previously land that was used for growing vegetables and for putting animals on farming, and then obviously that pushes out into other types of environments as well. So how we actually are smart about working within the constraints that we're in, but supporting different infrastructures and thinking about things differently. So people will be familiar with bees on rooftops. Really simple things to keep pollinators in the city, not putting major roads through environments where a lot of animals travel, so they can actually migrate as they have been able to do previously. So yeah, it needs very careful design considerations built in.
Thank you. Are there any questions from the audience? You can raise your hand and ask a question. I'll go with a question for Priya here. Priya, very interesting, innovative solutions coming out of India on that front on digital health. How much do you think it's like sustainable and transferable across contexts? Models like those.
Well, I mean, a lot of this actually depends on, as you said, context, because a lot of these are now being, they are kind of response-driven models. The pandemic has started them. They've kind of come out to address that, but their sustainability, of course, depends on lasting beyond the pandemic. I think a lot of them are transferable, which is why I kind of highlighted two. One that was largely volunteer-driven, which are, had a lot of volunteer doctors who were actually trying to address primary healthcare issues using telemedicine. And the second, of course, is, having psychologists and mental health and well-being, again, is something that is transferable across countries and contexts today. So I think the beauty of digital solutions are that, one, they can be tailored to context because technology can be architected based on geography. But we also have to, look at the flip side. I mean, what I'm trying to say here is, Ankur, technology is not the answer to everything. There is what is called a digital divide that is also happening now in many countries. Some countries have accelerated with the kind of technology answers because we have had to deal with a lot of systemic state capacity gaps. But then there are other countries, including large parts of Africa, where technology is not as rampant, or maybe even some of the fragile states where technology isn't that rampant, but has to be augmented or supplemented with other innovative partnerships in order to kind of reach the last mile. But short answer to your question, yes, there is a lot of role for applicability, and that's already happening as we speak.
Thank you. And before closing, we'll take a question from Paris. Paris has raised his hand. Paris, do you want to unmute yourself and ask a question, please?
Yeah, I just thank you, Priya. It's such a wonderful presentation. Being the neighboring in a neighboring country from India, I'm living in the border of India and Nepal. My just concern is a recent report in Times of India, which categorically said that private health institutions were not generous to support COVID-19 control in India, which is a big report, which contradicts with this consortium's work. So is there a gap between media and the work they are doing? I just wonderful consortium, very nice work doing, social corporate responsibilities functioning, whereas one of the major media reports that private sector was indifferent in COVID-19 control in India, which is the recent report of Times of India. So just, are you aware of that, or just media is not generous to the people working there?
Brief response.
Well, Indian media, like any media, has to be taken with a pinch of salt because there are so many views. But, it's interesting. There are two ways of looking. I mean, I would look at the role of the private sector essentially as non-state actors. You have the more traditional private sector that were really slow off the starting block when the pandemic came through, and were equally as unprepared as the government in kind of dealing with the wave of insurgent cases, in dealing with something like COVID. I mean, there was a lot of breakdown of the very determinants of health in urban areas, and the private sector, the traditional private sector, private hospitals, private diagnostic labs were backfooted as much as the government was. There was also, very usurious, work going on. There was exploitation in some cases. But here, what the difference in this natural experiment was that it actually started with technology companies themselves. And the interesting thing that I have been looking at digital technology for a while now, and the genesis of a lot of these technology companies. A lot of them started with an ideological bent of mind. And many of the technology entrepreneurs actually worked in other areas, but had a social bent of mind, saying that how can we use technology to bridge a gap, literally, in a system that's really faltering right now. And so a lot of these startups were, perhaps addressing other things. There were more mature startups that were really looking at, say, more advanced level of primary care and teleconsultation. But they started funding this together, saying that at some point, health has to be looked at as a public good. And perhaps technology can begin to, augment that in more ways than one. So I thought that was quite interesting about the ACT partnership, because I also got to speak to a lot of the founders who were technology players in other sectors. They were dealing with technology and supply chain. They were dealing with technologies, for example, in cash payments, quick money, microfinance and stuff. But then they all kind of banded together and said, how do we react to specific priorities from essentially actually a supply side? And how do we kind of address that? So yeah, I hope that kind of answers your question.
Thank you. I think we've reached the time, so let's put a hand together.
Thank you, Priya. Thank you.
for our wonderful speakers, and also really looking forward to our supplementary session specifically around precarious employment, and really welcoming you all to join us there and continue some of the discussions we've had today. So thank you, Hannah, Gerry, and Priya for your fantastic presentations.
Thank you, Ankur.
Thank you, Ankur.
Thank you.